I'm Dr. Cynthia Stuenkel. I'm a clinical professor of medicine at the University of California, San Diego. I'm here at the Menopause Society meeting and have been talking about primary ovarian insufficiency. Well, it's a really good question because there are a number of different conditions. So once we've established the diagnosis, it means that this woman under 40 has stopped having menstrual cycles. We've established that her follicle stimulating hormone is elevated and her estradiol is low. And we might have even repeated that just to be sure. Then there are a number of different tests that we do in an effort to see if we can figure out. We often can't establish the cause, but sometimes we can. So we recommend a chromosome analysis to look for Turner's syndrome mosaics. Most Turner's girls will have primary amenorrhea and that they won't go through puberty on their own. But if they have the mosaic, then they can have menarche, have natural cycles, and then go on to have primary ovarian insufficiency. We look at another genetic test called Fragile X premutation. This is a gene that's associated with something called Fragile X syndrome, which is often in little boys associated with intellectual disability and autism. But in women who have just what's called the premutation part of it, about 1 in 5 of those will go on to have primary ovarian insufficiency. So we think this is really important to identify because in this kind of situation, this woman is going to merit some genetic counseling and possibly some family counseling and evaluation to know, like, is her little sister vulnerable to this? Is this something that's going on in other parts of the family? Other things we look for are signs of autoimmune disease, and we measure antibodies to the adrenal gland. It's called a 21-hydroxylase antibody. And the measures that we have available for ovarian antibodies just aren't so good. And so if women have a positive adrenal antibody, then that's a sign that she needs her adrenal function evaluated, because we know that adrenal insufficiency and Addison's disease can be a very serious disorder. And then we look for some other autoimmune things too. We usually look for thyroid function in those women at least, and then just see if they have any other skin findings like alopecia or something that might give us a clue that they have a larger kind of syndrome. So if she has her POI from one of these causes that I talked about, chances are hormone therapy is going to be fine for her. In general, we like to start it right away at the time of the diagnosis. And it wouldn't have to be with postmenopausal hormone therapy. It could be with oral contraceptives. And some young women appreciate that because their friends have pills, or it somehow feels more comfortable to them to do that. So depending what else, and particularly if she doesn't want to get pregnant, then contraceptives make sense. The question you asked is, how does that compare with therapy in an older woman who has a natural menopause? Women vary a great deal whether or not she even wants to talk about hormone therapy. She may not be that bothered that she feels that she needs symptom treatment. She may just say, I'm not interested in hormone therapy. And then it's our job as clinicians to sort out, is hormone therapy going to be safe for her? So we look at things like, does she have any contraindications in the way of having had an estrogen receptor positive cancer, like a breast cancer, extensive uterine cancer, even certain ovarian cancers now would be of concern. We look to see, what is her risk for heart disease? Is she hypertensive? Does she have diabetes? Does she have metabolic syndrome? And that might alter the kind of hormone therapy that we would be willing to offer her. We use a much lower dose in a postmenopausal woman generally. At least we would start at a lower dose than a young woman with POI. We're going to try to match what her body's been making. So we might give her a dose like a 100 microgram patch, whereas in a postmenopausal woman it might be 50 or 45 or 35 or 25 micrograms, even a very low dose if she just says, oh, I'm really doing pretty well and just maybe want to take the edge off. So the dosages would be different, and then the duration would be kind of the third factor. Because the young women, we want to start them and we want them to continue until the usual age of menopause, about 50 or 51. The older women, we kind of give them, a few years and see how they're doing, see what other health concerns they have, see what they're comfortable with, and then we can decide if they want to continue longer, or if they say, I feel better, I'm going to try weaning off and doing a time without it and see how it goes. So the first question about early loss is fertility. And fertility is a really tough one. If she's coming in and she already has primary ovarian insufficiency and she wants to have any chance possible for pregnancy, we usually try to measure two more hormones. One is called an anti-Müllerian hormone. That's kind of a hormone that's made by the follicles in the ovary that can help us get a sense of her ovarian reserve, and then actually do an ultrasound and count the follicles that we can see in the ovary, and that's called antral follicle count. And then she should be referred really to a fertility expert right away. It's not likely, but it's possible that she can, conceive, and they help sort that out, and so that's an important thing. And then it's also important to her just to talk about other means for family, creation, that she could adopt some, depending on where they live and their ideas and ideals, can consider surrogacy, for example. And finally, they could have egg donation or even an embryo donation. So I think we should give women hope that there are ways that they can build a family, for sure, and more or less participate in a pregnancy depending on what their situation was. So issues related to bone health are very important, because we know that for women, we reach our peak bone mass or our peak bone density about the age 30 to 35. So if this young woman has had primary ovarian insufficiency and effectively lost her own endogenous estradiol at a much younger age, she hasn't had a chance to build up her bone in the same way. So we think that the estrogen we give to her will help her not lose any more bone and potentially build her bone. It's much safer, I think, using estrogen in these young women than other drugs that we have available in our whole huge armamentarium for osteoporosis in older women. A couple reasons of that. One, we don't want her taking some of these drugs if she should have the good fortune to become pregnant. Number two, we don't want to be administering these drugs and having them in her body for 20, 40, 50 years, right? Because we know there can be some long-term consequences or complications, if you will. So that would be another reason that we would really encourage her to get on hormone therapy and to stick with it. So the last question you asked about was cardiovascular health. I think one of the most important things she can do, we have some evidence that taking estrogen for these young women can help promote cardiovascular health, but it's lifestyle. Look at how she lives. Please don't smoke. Be mindful of the amount of alcohol that you ingest, and then try to exercise and try to eat a healthy diet, and being mindful just of those simple things. Getting the amount of calcium and vitamin D or sunshine is important for her bone health too. But so much of what we can do, there's a Life's Essential 8, they call it, that includes diet, exercise, maintaining a healthy weight, knowing that her glucose is okay, knowing that her lipids are okay, because we know at menopause our lipids can increase, and knowing that her blood pressure is okay. And then finally, they've added the 8th one, which is getting a good night's sleep and making sure her sleep is okay. So just, I think, a talk about helping to be mindful of these things, even as a young woman. It's not like, oh, I'll wait till middle age. But it could be very helpful for her to just get off on the right foot to have the best possible life and health going forward. One of the things that people are looking at, and we reviewed some of this for the Endocrine Society a few years ago, is just ways to kind of slow down the loss of the eggs or revitalize the eggs. For women, for example, who are undergoing cancer treatment early on and have a little bit of time to prepare, they can either have a part of their ovary, a very small part of their ovary removed and kind of put on ice. They can go through an ovarian stimulation as though they were doing IVF, harvest their eggs, put those on ice. And so I think people are getting better and better with some of the onco-fertility kind of things for the women who lose ovarian function because they've been treated for cancer, because that's one of the, what we call the iatrogenic groups, one of the things that trying to make them better. But we're doing such a better job with cancers now that these women are living longer. So if they can get some of their ovarian tissue or eggs on ice, I think that's a peace of mind, and that's a good thing that they can do for their future fertility. Some of the other things that are being tried, I would say, are still experimental at this point.